invitation. It's a great honor to be part of this symposium. So my topic is antigrade parallel wire escalation. What are the favorable features for antigrade CTO angioplasty? It's usually a tapered proximal cap, short occlusion, and a good landing zone. But also, if you have a very bad collateral channels, which means you can't do retrograde, then you have to work towards getting artery open through antigradely. So in the antigrade techniques, there are four main things. One is a fine channel crossing, which is basically a functional CTO where you can cross with some slippery wire like Fielder XTA. Then you have a wire escalation where you have to use some heavy tip wires. And there's something called wire redirection. So for example, if you're going bits towards subintimal, then you can redirect the wire in a different angle. If it's not working, then we choose parallel wire. And then there's something called ADR. So my topic is to just speak on parallel wire. So parallel wire is basically the first wire goes subintimal. Then you use that as a landmark to try and redirect your wire. So if you do a schematic here, so let's say the wire goes more towards the subintimal side. You take a second wire, use it as a landmark, and then try and re-enter. So I'll show you a case. So this is an RCS CTO. Excellent retrograde collaterals from the left system, almost like epicardial, which we try not to use it unless we have to. And antigradely, you see it's a short occlusion with a nice tapered cap. So we should try and use this antigradely. So we started with the Corsair. Gaia 3 was not making any progress, so we took a Confianza. You could see clearly gone off track. So using this as a landmark, we took a second wire. This is again a Confianza, more towards the lumen. Obviously, we should not just get carried away with this and push the wire. You have to check in the other view, which is the orthogonal view, RAO, and you see the wire is a bit more in the same place. So we have the confidence to push the wire, and then again confirm the epicaudal to make sure that you are not gone subintimal as you go down, and then you are happy with this. So this case was difficult because I could not spin the Corsair or the microcatheter despite using a supportive guide. So we had to nudge the microcatheter and put a rotor wire, and then did the rotablation with a 1.5 burr, and we had a good result. So second case is a circumflex CTO, which is always a bit difficult. So you could see here it is got a collateral from the right coronary artery, and this is what we are dealing with. It's a short occlusion, tapered tip, but the landing zone is in a bifurcation. So this excludes ADR because you lose one of the branches. So you have to try and do this antigradely. So we start with the Corsair Pro and the Fielder XTA. We made some progress, but then it stopped going. So we took a Gaia 2 wire, which went off track. As you could see, it's going subintimal. Then we did the redirection. So we brought back the wire and try and change the direction, but it also went subintimal. So we then used Sasuke, which is the dual lumen microcatheter, and then took a second Gaia wire and penetrated more inside. So if you could see here, this is the first wire, and we've taken a second wire, which has gone more medial to that. And we confirmed in the other wire position, so we were happy with this. So we pushed the wire, and we were in the true lumen. So obviously we finished this case. We didn't use a stent here, we used a DCB and a stent at the top end. Third case, again, a RCS CTO. This is a bit more complex, a long lesion. Collaterals are excellent, but the distal landing zone is not very great. So again, it takes away ADR option. So this, again, we started with the Gaia 2 wire. So kind of gone subintimal, as you could see. So use this as a landmark and took a second wire. And then we made progress, checked in the view here. We were happy. So we pushed the wire, and we were in true lumen, and we finished this case. So I'll show you a slightly complex case. This is a complex parallel wire technique. So this patient kind of revived study, as the previous speaker mentioned, about severe impaired LV function, got an ICD in place, blocked LAD, blocked right coronary artery, extremely symptomatic. So obviously to open this, you have to do the LAD antigradely, because if you use ADR, you lose all the diagonal septal. So we started off with a Gaia 3 wire and a microcatheter. The wire went into the diagonal, which is okay, not a bad sign. So we then took a dual lumen catheter, Sasuke, and then penetrated the cap with the Confianza Pro 12 because Gaia 3 was not helping. And as we progressed this further, we went subintimal because it's quite calcified. Normally it takes a more easier route, which is subintimal. Then we put the microcatheter, which is the Sasuke, on this wire now. It was obviously in this wire before. And then we took a second Confianza Pro wire and directed more towards the architecture of the vessel. And we confirmed in the AP cranial, RAO cranial, it looks good, but we have to check in the other view. So we did a LAO cranial, and you see the wire is going more outside. And when we did the true lateral, you could see we are completely off track. So we had to bring the wire back and then redirect it, which is what we did. And we were relatively in the good position. So we pushed it further. And after this, we had difficulty in spinning the corsair. So we used the anchor balloon. This is a very good technique, actually. So you put an anchor balloon in the diagonal. You ask the second operator to tug on the balloon. Then you can spin the corsair. You could see how the corsair nicely goes forward there. And then we did a tip injection, confirmed that, and then we stented this. So then patient came back and we did the RCA later. Don't be deceived by one view, because it's very easy to get carried away. So for example, here, this is LAD CTO. The wire looks so nice. It's very easy to spin the wire. But if you look at the lateral view, you are completely off track. So you have to bring back and change it. So here we used a parallel wire, and then we were in the true lumen. So last case, again, the complex parallel wire technique. So this patient, elderly 80-year-old with angina, previous bypass, blocked vein graft to marginal, patent lemma to LAD, and vein graft to RCA. So he had the blocked vein graft and a blocked circumflex or a OM2, very calcified. So in this case, we had to use an angulated catheter to penetrate the cap because it was not giving us enough support with the normal microcatheter. So we took a Gaia 3, and when we advanced, we were clearly in the wrong place. So obviously we used this as a landmark, and then we took a second wire, which also went subintimal. In this case, there was no retrograde option, so we have to persist. So we then took the second wire back, the first wire back, so this wire back, and then redirected it. And you saw we were in the true lumen here. Now we ballooned it, and then this is post-POBA. Dissected. So if I do put stent here, very likely I'll lose this branch and this branch. So we decided not to do any stent here. This was an elective case. So we put a DCB in the circumflex and in the marginal. Now, this is the final result. I know it doesn't look nice, but there is TIMI3 flow. We accepted it. I told the patient I'll bring him back in 3 months and treat with a stent. Now, when I brought back, he said he's completely asymptomatic. He's doing all the activities back. In fact, he was asking me why I'm having the angiogram. I said, requested, can I at least take some pictures? He said, yes, you can take. So I took the pictures. And look at that. It looks so nice. Now, it's obviously still not looking great, but TIMI3 flow, patient asymptomatic, so I have got no justification to go and stent this. So I left it. Now, interestingly, 4 years later, he had ACS. So he came with chest pain. So we did the angiogram, and that treated vessel looks really nice. So if you look at the 3 post-PCI, 3 months follow-up, and 4 years. It's a great DCB result with a long-term follow-up. So I didn't put any metal here. My initial plan was to put a metal. Okay. So these are the cases not for DCB straight away. So maybe with time we can do this. So my conclusion, parallel wire technique is kind of a losing art. Not many people are doing it. It works very well with short occlusion. It maintains original artery anatomy because you're not dissecting it, so you're not creating hematoma and things, so you don't have to bring the patient back and re-optimize the stent. It is not a rocket science. It gets better with practice, worth a try. And I would like to obviously dedicate my mentor, Dr. Suna Nakamura from Japan. He has been mentoring my CTO skills since 2015, and thank you.